Manoj got logged out. Good evening, friends. Today our guest speaker is Dr. Rachel Grace from Boston. She will be lecturing on pyruvate kinase deficiency. This webinar is brought to you by Mumbai Hematology Group. It is supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and the team Intas, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Rachel Grace from Boston. All our discussants who are very prominent and eminent pediatric or adult hematologists or hematopathologists, and you participants from various parts of the globe for sparing your Saturday evening, afternoon or morning. Today we have registration from 20+ countries. The subject was announced almost 6 months ago, and there has been a lot of enthusiasm in registering. Our website is www.mhgindia.com. There is no password. You are most welcome to look at our website for all our future academic activities. And we also have some of the lectures put up there that have been held during last 3 years. Tomorrow morning at 11:30 Indian Standard Time and 8 a.m. French time, we have Dr. Roselyne from France speaking to us about female breeders. And we also have Dr. Mukul Agarwal from Delhi speaking to us about surgery in hemophilia. So that's tomorrow morning. Our discussions today include various important personalities, and they are put up over here in alphabetic order. I'll just introduce them to you. We have Dr. Abhilasha Sampaga from JNMC Belgavi, Dr. Akshaya Mandolvi from Suraksha Diagnostics, Kolkata, Dr. Amit Jain from Thalassemia Care Center, Mumbai, Dr. Amita Mahajan from Indraprastha Apollo Hospital, New Delhi, Dr. Anshul Gupta from SGPGI, Lucknow, Dr. Deepak Bansal from Advanced Pediatric Center of PGI, Chandigarh, Dr. Jagadish Chandra from ESI Modern Hospital and PGI, MSR, New Delhi, Dr. Kunal Goyal from Institute of Hematology, Medical College, Kolkata, Dr. Neeta Radha Krishnan from PGI, Noida, Dr. Priyanka Agarwal from Banaras Hindu University, Varanasi, Dr. Rajat Bhattacharya from KK Women's and Children Hospital, Singapore, Dr. Purva Kanvinde from Vijayawada Hospital for Children, Mumbai, Dr. Sangeeta Mudliar from Vijayawada Hospital for Children, Mumbai, Dr. Shruti Kakka from Dayanand Medical College Hospital, Ludhiana, and Dr. Siddharth Todadri from CMC, Vellore. It's my privilege to introduce the guest speaker for the day. This is, I think, in last 3 years, for the first time, we are having the subject of pyruvate kinase being discussed. And the speaker is a huge authority on this subject, Dr. Rachel Grace from Boston. She is a pediatric hematologist at Dana-Farber Boston Children's Cancer and Blood Disorder Center. She's an associate professor at the Harvard Medical School. She's the medical director of the Hematology Clinical Research Program there. She's a recipient of the Blanche P. Alter Investigatorship in Hematology. She received her MD from Brown University and received Masters in Medical Science from Harvard. She completed her pediatrics residency at Boston Children's Hospital, Pediatric Hematology Oncology Fellowship at Dana-Farber. Her clinical and research interests are focused on improving outcomes of children with immune cytopenias and rare congenital hemolytic anemias. She's the director of the Pediatric ITP Consortium of North America, a group of over 50 sites in North America focused on improving ITP care for children. She developed the Global Pyruvate Kinase Deficiency Natural History Study and has provided leadership in clinical trials for treatment of children and adults with pyruvate kinase deficiency. She's going to lecture us on pyruvate kinase deficiency. And over to you, ma'am.
Thank you so much for that introduction. And I'd like to thank the organizers and the members of the Mumbai Hematology Group for inviting me to give this presentation this evening on new developments in the management of pyruvate kinase deficiency. Before I get started, here are my disclosures relevant to this presentation is that I received research funding from Agios and a consultant for Agios, and I'm also a member of the PK Deficiency Advocacy Advisory Council. To give you an overview of what I'm going to be talking about today, I'm first just going to give a basic overview about pyruvate kinase deficiency and what was known about it up until about 5 or 10 years ago. Then I'm going to talk a bit about the findings from the PK deficiency natural history study, the largest registry to date for this rare anemia. And then I'll spend most of my time talking about exciting therapeutic developments in pyruvate kinase deficiency. And then I'll end by talking just a little bit about PK activators and clinical trials for treatment for other hemolytic anemias. Red cells, as you know, lack a nucleus, and so they can't synthesize DNA, RNA, or proteins. And as compared with the reticulocyte, the mature red blood cell doesn't have mitochondria and therefore lacks an electron transport system for oxidative phosphorylation. But the red cell needs to maintain an adequate supply of ATP. ATP is necessary for the red cell to be able to pump cations against the electrochemical gradient, to maintain membrane phospholipids, and to protect the cell from oxidative damage. And so how does the red cell accomplish this? The red cell relies almost entirely on glycolysis as its source for ATP. And although most of us don't enjoy thinking about the glycolytic pathway or certainly memorizing it, it's understanding this pathway shown on the left that leads us to understand the red blood cell enzymopathies, enzyme defects that lead to rare congenital hemolytic anemias. Pyruvate kinase is shown at the bottom of the pathway, which converts phosphoenol pyruvate to pyruvate, and one of the final steps of glycolysis in an ATP generating step. With the deficiency in pyruvate kinase, there's a deficiency in red cell ATP, which causes the red blood cells to hemolyze after days or weeks, rather than lasting the 120 days of a healthy red blood cell. We can measure flux through the glycolytic pathway in red cells ex vivo. Patient samples can be drawn and spiked with carbon-labeled glucose, and metabolites can be measured as glycolytic flux occurs. Lactate in particular can be measured at regular intervals over time, which is shown in the graph on the left. This shows glycolytic flux with healthy red cells, that's shown here on the left, and then with patients with pyruvate kinase deficiency shown on the right. And you can see that patients with pyruvate kinase deficiency generally have decreased lactate production consistent with decreased glycolytic flux. In terms of the history of pyruvate kinase deficiency, there are several main investigators that are attributed with first discovering or reporting and understanding what's happening in the red cell in patients with pyruvate kinase deficiency. The first reports were from Selwyn and Dacey, who described abnormally low utilization of glucose in the red cells of these patients. And then DeGrucci reported low ATP in the red cell and elevated 2,3 DPG levels. And then really it's Professor Tanaka who first described and labeled the diagnosis as pyruvate kinase deficiency in the paper shown here. In understanding pyruvate kinase deficiency, one of the most important things to understand is what happens to reticulocytes in pyruvate kinase deficiency. As you know, reticulocytes have 5 times the energy needs of mature red cells. However, they have mitochondria, so they can rely on oxidative phosphorylation to meet this energy need. But the spleen is particularly problematic for reticulocytes in the setting of pyruvate kinase deficiency, because in the setting of the hypoxic splenic environment, red cells need to rely on glycolysis rather than oxidative phosphorylation. And in this setting, the reticulocytes can't meet their energy needs by glycolysis alone in the setting of pyruvate kinase deficiency. And so they rapidly hemolyze in the spleen in the setting of PK deficiency. And this is the reason why splenectomy is partially effective for this anemia, because there's increased survival of the reticulocytes, and also why there's this paradoxical rise in the reticulocyte count that happens after patients undergo splenectomy for pyruvate kinase deficiency. This algorithm shows how we think about hemolytic anemias in general. The The diagnosis of PK deficiency should be suspected in patients who are thought to have chronic and congenital non-immune hemolysis once a hemoglobinopathy or a membranopathy has been excluded. How do you diagnose pyruvate kinase deficiency? The diagnosis should be suspected, as I mentioned, in patients who have non-immune chronic hemolysis. And these are patients who typically have a low hemoglobin, an elevated reticulocyte count, an elevated indirect bilirubin level, and a negative direct Coombs or antiglobulin test. The peripheral blood film in these patients is usually bland without specific red cell morphology in patients who have an intact spleen. And this is obviously different than patients who have a membranopathy or hemoglobinopathy. And so once those two types of disorders have been excluded, a red cell enzyme disorder should be considered. And in these patients, there's an important role for both enzyme activity levels and genetic analysis. For when it's available, a low pyruvate kinase enzyme activity can be very helpful. However, it's difficult to get this assay. It's difficult to have accurate enzyme activity levels measured. It's obviously not possible to do this in the setting of patients who are regularly or recently transfused. It can be low in patients who are PK carrier, so it doesn't necessarily help you differentiate between disease versus being a carrier. It may be that because of the elevated reticulocyte count that you need to get other enzyme levels for comparison to look at comparison of one red cell age-dependent enzyme to another, for example, hexokinase and pyruvate kinase. And so there's a strong role also for genetic testing or PKLR gene testing in this disorder because enzyme testing can be so tricky, both in certain clinical scenarios, but also because it's difficult to do this assay. However, for genetic testing, there's 20% of patients have newly described mutations that haven't been described before, which can make it difficult to interpret these results. And genetic testing isn't available everywhere. It's expensive, and it may not be available to patients. And so there's a role for both of these tests, which I'm going to talk a little bit more in a later slide. How common is PK deficiency? It's extremely rare, as you all know from your clinical practice. The prevalence is thought to be somewhere between 1 to 3 per million people. There's certainly a higher frequency in certain patient populations. We see that in populations with a founder effect. For example, in the United States, in the Pennsylvania Amish community, there's a founder effect and a much higher incidence of pyruvate kinase deficiency. We see it when there's consanguinity. And then we think there's an increased incidence in certain areas, perhaps from selective pressure related to malaria. And interestingly, the estimated prevalence of pyruvate kinase deficiency in certain populations is thought to be much higher than what we see in clinical practice. And people have spent a while thinking, well, why what we see isn't what we would predict? And it may be because some patients are misdiagnosed. They're said to have hereditary spherocytosis, but actually they have PK deficiency because all the testing isn't available or hasn't been done. Or perhaps a patient has such a mild clinical phenotype that they haven't undergone any testing, so they don't know that they have this issue. Or perhaps for patients who are very severe, it leads to in utero demise, and it's never diagnosed in that setting. But it's not exactly clear why the prevalence seems to be lower than what's estimated from genetic testing. So I'm going to move on now to talk about the pyruvate kinase deficiency natural history study. But I'm going to start first by talking about some preclinical data that led to the development of the natural history study and sort of one of the reasons why this registry was developed. About 10 years ago, I was invited to meet with scientists from a company in Cambridge, Massachusetts, which is just nearby to my hospital, because in their research to target the Warburg effect in their preclinical oncology work, these scientists discovered a pyruvate kinase activator. And the figure on the left shows pyruvate kinase protein in blue, and in yellow is shown mitapivat, which binds at the dimer-dimer interface of the protein, and it's away from the active site and also the areas affected by the most common mutations in patients with pyruvate kinase deficiency, which are shown in green. This figure that's shown here in the center shows data that led to the company's initial excitement about mitapivat. And they shown here is recombinantly expressed wild type shown in red and mutant PK protein shown in the other colors that were incubated with mitapivat. And the graph shows that there's a 2 to 6 fold activation with exposure to mitapivat And you can see that the mitapivat activates wild type pyruvate kinase protein, that's in red, as well as the different color mutant proteins, although variably for the different gene variants. And then in addition to this data, there were preclinical studies that showed that the drug could stabilize unstable variants. The figure on the right shows the very unstable R510Q variant, which is common in the US and in Europe in the PK deficiency population. And without the drug, the solid green boxes show the very short half-life of the protein. And then with ex vivo exposure to mitapivat, the half-life of the protein, now shown in the open green boxes, is similar to what you see in wild type, which is shown in the red circles. So in the context of this exciting preclinical data, discussions were ongoing about clinical trials. But of course, in the setting of trying to think about clinical trials, you really need to understand the disease and the natural history of the disease, including very important and key clinical questions, including what was the spectrum of severity in patients with pyruvate kinase deficiency, how often were patients transfused, is splenectomy effective in this condition, what are the complications that patients have, and how are they managed? And we realized that we would need to understand this disease better in order to develop clinical trials that had clear endpoints, which assessments and disease measures were going to be useful as outcomes of the trial. How would you decide which was the important clinical efficacy primary endpoint, and what would be a clinically meaningful change in that endpoint? And then, of course, not just from a clinical trial perspective, but talking more about this rare disease from a clinical care perspective, it's important to figure out what do we know about this disease so that we can manage patients better in terms of monitoring for problems over time and following treatments that have the best outcomes. And so the goals for the natural history study were to define the disease, to track the patients over time, to understand their phenotypes, understand what is the clinical standard of care in different areas. Could we identify biomarkers that correlate with disease course? What could we identify about disease features that might tell us more about who would encounter complications? What's the frequency of manifestations and complications? And then to describe better both inter-patient variability, but also intra-patient variability over time. And then the hope too was potentially to improve diagnosis and thinking about that disconnect between what we see in clinical practice and what's the estimated prevalence of the disease. And then with a kind of long-term hope of creating guidelines so that we would be able to monitor and treat patients more effectively. And we knew we would succeed best in this very rare disease if we had a community effort globally and a plan, of course, to share data widely as we uncovered new things. So this was what led to this development of a natural history study, which was an observational study. It had a retrospective component where we collected clinical data and laboratory data at enrollment, and then patients were followed prospectively over the course of 2 years. Patients also completed patient-reported outcome surveys at each of the annual time points. The study had 28 IRB or ethics committee approved sites with 22 sites in North America and 6 sites across Europe. And as part of enrollment, participants who hadn't previously had genetic testing had PKLR testing through the study, either through Dr. Pat Gallagher's lab at Yale in the United States or Dr. Paolo Bianchi's lab in Milan, Italy, to make sure that all the patients in the registry had a clear diagnosis. And then there were several important sub-studies that I'm not going to talk about during this presentation to look at red cell metabolite levels and PK protein levels and enzyme activities. And that was opened at a number of centers for the study as well. And enrollment is complete now for this registry. Over the first 2 years, 254 people enrolled who had a confirmed genetic diagnosis. In this cohort, the median age was 19, ranging from birth to almost 70 years old. Half of the patients who enrolled were children and half are older than 18. This just represents how strong the pediatric centers were in the study, not that this disease affects children more. Importantly, 22% of the participants were from the Amish community. And those people who were from the United States, from Pennsylvania, were mainly followed by one physician, Dr. Holmes Borton. And so this population, which represents a substantial group from the natural history study, is as important, but also it's important to note where were there differences between that subpopulation and the rest of the population? And I'll point that out as I go through. Approximately 2/3 of the enrolled participants were from the US or Canada, and 1/3 were from Europe. As I mentioned, PK deficiency is genetic, it's autosomal recessive, it's caused by homozygous or compound heterozygous mutations. Most patients are compound heterozygous. More than 300 mutations have been described, and we knew previously that most of the mutations were missense mutations, and these generally cause decreased catalytic activity of the protein, decreased protein stability, or decreased protein expression. And we saw in this cohort that 123 different mutations were described. So this is where it becomes difficult to look at the genotype-phenotype relationship. If patients are compound heterozygotes, there's more than 300 mutations. And in just this small 250 plus patient group, there's 123 mutations. It's very hard to look at that relationship. In addition to that, 50 mutations were found in this cohort that hadn't been previously described. So this also what makes it difficult to make a diagnosis in this patient population is that we're still uncovering new mutations. We saw too that the majority were missense mutations. They were in 85% of patients because so many patients are compound heterozygous. And interestingly, what we saw in our patient population, that even in patients who were homozygous for the same gene mutations in those small cohorts, there was still wide clinical variability, that patients had quite different transfusion profiles, different baseline anemia levels, and different complications. And I just highlight here the most frequently reported mutations that I found in the literature, and you'll have to tell me if this is what you see too in your clinical practice for patients who have had genetic testing. So what are the advantages and disadvantages of different types of testing? I've already mentioned some thoughts about testing. Interestingly, in this cohort, which wasn't very long ago, only 1/3 of patients from North America had had genetic testing prior to enrollment in the registry, and about 2/3 from Europe. So still a substantial number of patients who aren't getting genetic testing, but you can see there's global variation in how available this testing is or how much it's pursued for patients. And interestingly too, that 8% of patients who were enrolled thought to have a diagnosis of pyruvate kinase deficiency didn't have 2 PKLR mutations, which we could talk about in the discussion too about why that might be towards the end. And I put here in the table some advantages and disadvantages when we think about genetic testing versus the enzyme testing. I mentioned already that we can't do enzyme testing in transfused patients, that the stability of the sample is problematic for enzyme testing, but enzyme testing is more likely to pick up the answer in some ways than genetic testing. Genetic testing is obviously the way to go with prenatal diagnosis, and they're both variable in terms of does it give you a yes or no answer, and using them together is likely the way that people should be approaching this. And that's based on a report that came from a global PK deficiency international working group that was put together in 2016 with 24 experts from 20 centers of expertise, with basically lab centers of expertise, where they looked at current gaps in the diagnosis of PK deficiency and established these diagnostic guidelines with specific guidance with regard to lab testing. And they just, this algorithm here is a bit busy that they put together, but really highlights the need in many patients to basically do both kinds of testing. If the enzyme level's up low, you need to do genetic testing to confirm. If the genetic testing shows a new variant, you probably need to do enzyme testing to confirm as well. Despite the challenges of looking at the genotype-phenotype relationship with all the different gene mutations, we did try to look at that in our cohort, and we did find relationships between the genotype and the patient's characteristics. You can see across the groups here that we've kind of bucketed them in a way that's not perfect. So patients who had 2 missense mutations are here on the right. Patients who had 1 missense mutation and 1 more drastic mutation, like a frame shift or splice variant, shown in the middle. And then patients with 2 drastic mutations are shown on the left. And you can see that patients who have 2 drastic mutations were diagnosed at a younger age. They have a lower hemoglobin. They had more transfusions. They generally had a higher ferritin level. They were all splenectomized versus a smaller rate in the other groups, and had a higher rate of iron overload. But I think it's important also to note this group over here had a very wide range in hemoglobin, with some patients really being quite effective with a very low hemoglobin. these patients also needed transfusions. These patients also had iron overload and also were heavily splenectomized. So there's definitely this relationship, but it's not to say that these patients have a mild phenotype, because they clearly don't when you look at them overall as a group. And we look too at iron status, particularly in patients who weren't getting regular transfusions. Obviously, in patients who are regularly transfused, they're all going to have iron overload and need treatment. But for patients who are not being regularly transfused, we look to see what are the clinical characteristics of patients who had iron overload, shown on the right, versus no iron overload. And you can see that these patients who had iron overload tended to be older, although we're still young adults, tended to have a higher rate of splenectomy, tended to have a lower hemoglobin and a higher bilirubin. Interestingly, though, patients who had iron overload who were never transfused, there was an 8% rate of iron overload in patients who had never been transfused. So it was recognized through this data and other components of the natural history study that we needed to be monitoring iron even in patients who had never been transfused for pyruvate kinase deficiency, that this could be a problem in patients in this condition, regardless of their transfusion status and really regardless of their age too. And so this shows the relationship in the figure here of MRI iron testing versus ferritin testing. And we saw, as I already mentioned, that this group overall in the natural history study had a high rate of iron overload, 44% if you defined iron overload using ferritin, even higher, 85% if you defined iron overload by MRI. But of course, this might have been an overestimate because you had to have an MRI in order to report this. But I think, what was interesting is that we could see, just like in other conditions, that there's a good correlation on a population level between ferritin and liver iron as measured by MRI. But on a patient-specific level, there isn't always a good correlation. And of the 29 people who had a liver iron measurement by MRI and a ferritin less than 1,000, half were found to have an LIC over 3. And so this speaks to the need to really thinking about an MRI study if it's available at least a one time point for these patients, perhaps even if their ferritin is less than 1,000. This is not data from the natural history study, but I didn't want to miss it because I think it's an important point about pyruvate kinase deficiency. One interesting aspect about creating a registry is that you don't necessarily know what to ask for, what to ask about if a disease is rare and you don't know everything about it. So we asked about bone fractures as part of the registry and found a fairly high rate of bone fractures. But we didn't ask as detailed as I would now about bone health. And what we found actually was through the clinical trials, which I'm going to talk about later, through screening DEXA scans for other reasons, that there was a very high rate of osteopenia and osteoporosis in this population at a young age. And of the 159 patients who were enrolled in clinical trials, 85 or 54% had osteopenia and 33 or 20% had osteoporosis based on their medical history or DEXA scan. So very, very high rate of poor bone health. And you can see this is spine health shown over on the right. And you can see these two groups combined represent a significant issue for bone health in these patients. So it's very clear that these patients also need to have DEXA monitoring as part of routine healthcare, starting at late adolescence or early adulthood. What else did we learn from the natural history study? So we all are aware of complications of hyperbilirubinemia and anemia in newborns, but it's important to recognize that these newborns may have more severe presentations, including in utero or intrauterine growth retardation, where they're small or born prematurely, but also after birth with skin extramedullary hematopoiesis, severe hepatic failure, fulminant presentations with hyperferritinemia and other cytopenias like thrombocytopenia. And so this diagnosis needs to be suspected in babies who present more fulminantly with liver failure or some of these lab abnormalities where the anemia may not be the most obvious part of their clinical presentation. Children and adults with PK deficiency obviously experience a number of complications, and these are highlighted on this figure. Patients I don't have on here experience pallor, jaundice, and fatigue, but these are some complications I've listed here that we looked at the rate of in the natural history study, including this rate of pulmonary hypertension, which is quite severe and impacts quality of life, high rate of gallstones in this patient population. We already talked about iron overload, and osteopenia, and then this high rate of extramedullary hematopoiesis as well. What are symptoms reported in children and adults who have pyruvate kinase deficiency with anemia? There's daily symptoms that are reported, and you can see here, this was in a focus group separate from the natural history study where people reported the types of symptoms that they had. But there were themes of poor focus in school or work, poor endurance or exercise tolerance, episodes of worsening symptoms in the setting of viral or triggers or other stressors. And the jaundice in particular had a significant impact on quality of life. And I think we see this too in other congenital hemolytic anemias and underestimate the effect this has on somebody's general well-being. And then of course, gallbladder disease and issues, particularly in childhood related to splenomegaly. What did we find out about splenectomy in the natural history study? Well, we found that most patients had undergone splenectomy, 59%. And the rates were different between North America and Europe, with higher rates in North America. The average age was 5 years. I show here in the graph on the left the differences between the Amish and the non-Amish population, where the Amish population had a splenectomy at a much younger age for insurance and social reasons, and an older age in the rest of the cohort for reasons related to an infection and trying to prevent serious infection. The hemoglobin rise on average was 1.5 grams per deciliter, and the median post-splenectomy hemoglobin was 8.8, but you can see there was wide variability between 6 and 12. What were the predictors of a good response to splenectomy? This is something that comes up all the time in clinical practice. How will we know if the splenectomy is effective? Well, it's effective in the majority of patients in terms of decreasing transfusions and increasing hemoglobin, but it's not effective for everybody. So there'll be a population who has a splenectomy and they still require transfusions after splenectomy, where the hemoglobin is not significantly different. And all patients after splenectomy, unlike hereditary spherocytosis, will continue to have hemolysis after splenectomy. So it ameliorates the hemolysis by increasing the lifespan of the reticulocyte, but it doesn't actually resolve the hemolysis. So you're still left with the complications potentially of aplastic crisis, of gallstones, of other complications of chronic hemolysis. We saw that patients, in terms of predictors, that you were more likely to have a positive response to splenectomy if you had 2 missense mutations, if you had a higher hemoglobin prior to your splenectomy and a lower bilirubin. So the patients who perhaps had slightly more mild disease were more likely to have more benefit, and those with more significant disease were less likely to have benefit. And we saw a substantial rate of post-splenectomy complications, which included about a 10% rate of thrombosis, which is similar to what we see in other congenital hemolytic anemias, and a fairly high rate of sepsis of 7%. This just shows the transfusion status of patients who have pyruvate kinase deficiency, and this data was particularly helpful in thinking about the clinical trials. But what we saw was that the majority of patients were transfused at some point. Many patients were regularly transfused prior to splenectomy and then intermittently transfused afterwards. We saw that 21% of patients were never transfused. And then we saw, as I mentioned, that there was a group that was transfused heavily both before and after splenectomy. I just would make a note here that this data is a little bit subjective. It's objective, you get transfused or you don't, but the decision to transfuse is subjective. And there are some patients and some practitioners who choose not to transfuse for a variety of reasons. And I've listed here some of the hemolytic triggers that we see in patients with pyruvate kinase deficiency, with infections being a number one, but pregnancy also increasing hemolysis in patients as well. And I mentioned here, this is not related to the registry either. This is a separate study just to talk about what are the outcomes with stem cell transplant, because that also is data that has been available for a little while. And unfortunately, it's a very, very small cohort. So we don't know very much about stem cell transplant in this patient population. There was this worldwide effort to report cases from 1996 to 2015, and only 16 cases could be identified with the efforts of these investigators. These patients had a median follow-up of 2.5 years. And there was unfortunately a very high rate of chronic graft versus host disease in this population of grade 4, 38%. And unfortunately, too, the 2-year cumulative survival was pretty poor at only 74%. And it looked pretty clear that survival was better with the younger age of transplant, but it's really hard to know what to draw from this data in terms of what should be expected after some stem cell transplant. And it becomes very hard to give patients guidance with regard to this because there's just so little data. And then we looked at some of these relationships with the registry information to see, can you categorize severity using these genetic categories, which I already showed you that you can use these to predict complications, but you have complications even in the group that has less severe genotype changes. And then we tried to look at this too. Well, what about everyone who's had a splenectomy? Let's look at those who are transfused after and those who aren't. And we saw that these patient populations are pretty similar. So that decision about transfusions seems somewhat subjective and doesn't seem to impact these complications or isn't based on these complications. And then I'll just end with the registry data to talk about, well, is PK deficiency known well among hematologists? Like what do patients think? And this is work from the PK Deficiency Advocacy Advisory Council, which conducted a global study of 200 adult patients with PK deficiency and 75 caregivers with this goal of looking at communication between patients and their hematologists. And you can see here that this survey uncovered this unmet need in terms of education about PK deficiency with providers, where respondents, about half of them, felt that the hematologist couldn't answer their questions very well and wasn't really searching for answers to their clinical needs. And so this speaks to the need for all of us to continue to learn more about this rare anemia and to be sure to pay attention as we learn more over time. And there are opportunities between patient foundations and educational materials for patients to have more information about this disease and for providers to have more information about these disease. And I know for sure I'm not all inclusive here in what's available, but just showing you some examples of these things, including 2 new groups within the US that have formed for patients' support related to pyruvate kinase deficiency. So now I'm going to move to drug development and disease-modifying therapies in pyruvate kinase deficiency, focusing on PK activators. So going back to that discussion about mitapivat that I started with. So after that preclinical work that I showed you, the company moved to healthy volunteer studies looking at mitapivat, and this was phase 1 data, healthy volunteer data from a single dose mitapivat study looking at 2,3-DPG. So you can see here on the y-axis is 2,3-DPG, and you can see time here, and placebo is shown in blue. So with placebo, there's no change in 2,3-DPG. And as there is a single dose of mitapivat exposed to these healthy volunteers, which remember that mitapivat activates wild-type pyruvate kinase, you can see there's this expected decrease in 2,3-DPG with activation of pyruvate kinase. And because it's a single dose, the levels drop and then come back up to where the placebo is. So this is just as expected. And then they moved on to multiple ascending dose studies in healthy volunteers, now with ATP on the y-axis, and again, time on the x-axis. Again, the placebo is here in blue, and you would expect to see with exposure to mitapivat with multiple doses that perhaps there would be a sustained increase and that there would be an increase in ATP with PK activation, again, with the wild type. And you can see here this rise in ATP across the different doses. And when the dosing period ended after 14 days, you can see that the ATP levels drop down to the placebo range again. It's important to note that the healthy volunteers had a normal hemoglobin and a normal reticulocyte count, which didn't change over the 14 days. And so these results are more straightforward than we might expect in a patient with hemolytic anemia, in which we would expect to see there to be a change in hemoglobin and a change in reticulocyte count as there's an improvement in hemolysis. And so it may be more difficult to look at ATP and 2,3-DPG with those shifts in the reticulocyte count. It's important to note too, though, that in those healthy volunteer studies that there was a safety finding about aromatase inhibition, that there was a signal that there was a change in serum androgens and estrogens in patients who received mitapivat, and that these changes were during the period of dosing of the drug and then resumed back to the prior baseline when the dosing was stopped. You'll note those too, that with these red lines, that's the normal range, that the levels mainly stayed within those normal ranges but were outside of the patient's normal range. And so it would be important to follow this as part of the phase 2 studies and so on. And it has important implications, of course, now with consideration, especially in children. So with this exciting preclinical data, the phase 2 trial in adults with pyruvate kinase deficiency was initiated. This is a look at the design of the mitapivat clinical trial called DRIVE-PK. That was the first inpatient open label safety and efficacy trial. And this was in patients who are not regularly transfused. It was a multi-center 2-dose arm, and patients were followed over a core dosing period. And then there was an option for an extension phase if patients had a clinical benefit without concerning safety issues. This is the characteristics of the patients who were enrolled in the trial. You can see there were differences in gender, age between or I can tell you there weren't differences in gender and age during the 2 dosing phase core part of the study. This shows you the difference between the core and the extension part. But patients who continued treatment, you can see had a lower rate of splenectomy in terms of difference, and fewer, I think, had received iron chelation, which are shown here too. The baseline hemoglobin range of patients who continued on the extension overlapped with patients who had the patient's baseline hemoglobin in the main part of the cohort. And all continuing patients in the extension part had at least one missense PKLR mutation, compared with 81% of the patients who were initially enrolled. This is the clinical activity from that phase 2 study, which showed a significant rise in hemoglobin in half of the patients, with a mean maximum increase of 3.4 grams per deciliter in those with a hemoglobin response, and up to 6 grams per deciliter in the patient with the highest response. This y-axis shows the median, the maximum change from baseline in hemoglobin, and this dotted line shows an increase in 1 gram per deciliter and 2 grams per deciliter. And you can see there were patients who were right in between those 2 lines here. The individual colors on the graph show the dose of mitapivat the patient received for the longest period of the trial. Overall, there was no relationship between dose and response, where the likelihood of response didn't depend on that original dosing arm. But for some patients with a hemoglobin response, the magnitude of response varied by the dose. And many of these patients required a dose reduction during the core period. And so you'll notice those with the greatest response shown on the right of those patients with green and blue tended to be on the lowest doses of mitapivat. And the maximum dose on the ongoing phase 3 trials in adults is 50 milligrams twice a day. The hemoglobin response correlated with the patient's genotype. This figure shows again the maximal hemoglobin response on the y-axis and the individual patients on the x-axis, with color coding now by genotype. Patients with at least one missense mutation, which are shown in blue and purple, have the higher likelihood of response as compared with the 2 more drastic mutations, which are shown in orange. And you can see here, though, that some of them were right on the edge of a hemoglobin response or a small response. There was also a relationship between hemoglobin response and a higher baseline PK protein level. There were exceptions, though, to this observation, and the baseline PK protein level doesn't appear totally consistent as a predictor of hemoglobin response in these patients. These figures show the rapid and sustained rise in hemoglobin response, but also the response of hemolytic markers over the course of the extension period. You can see in red here, this is the hemoglobin response going from down here and then sustained over time. You can see the reticulocyte count response also decreased and was sustained over time, and the indirect bilirubin level decreased and was sustained over time. We saw that there could be withdrawal hemolysis if the drug was rapidly stopped rather than tapered. And so we learned that the drug needs to be tapered in patients who are having a hemoglobin response or where the robust responses were more robust than we would like it to be. With an increase in pyruvate kinase activity, we saw that there was increased flux through the glycolytic pathway. And I think this goes back to what I was showing earlier about glycolytic flux, and that you could measure the lactate production rate over time. And if this drug works on pyruvate kinase, it should increase flux through the glycolytic pathway. And that's exactly what we saw in specific patient samples as part of the study, that in those who didn't have a hemoglobin response, which is shown here, we didn't see a change in glycolytic flux. And those with a hemoglobin response, we saw a clear change in glycolytic flux. And so this really shows proof of mechanism of the action of the drug on glycolysis. We're going to take a look at safety of mitapivat. It's generally very well tolerated. The majority of adverse events in the trials have been grade 1 or 2 and have been transient. And when a later study, which I'm going to show in just a minute, involved a placebo, the rates in placebo were similar, if not higher, than the rates of the same AEs with mitapivat. The most commonly reported AEs were headache, insomnia, and nausea. And these rates didn't change with a longer period of follow-up. So based on the phase 2 data, 2 phase 3 trials were initiated, one called Activate, that's shown here, and Activate-T. Activate and its extension study was a phase 3 global double-blind placebo-controlled trial now in the same population, adults who are not regularly transfused. So patients were 18 and older, had to have 2 PKLR mutations with at least 1 missense mutation. So that was based on the prior trial that didn't have that eligibility criteria. Patients needed to have 4 transfusions or fewer in the prior year and a hemoglobin equal to or less than 10. Patients in blue and black received drug. Patients in gray started on placebo. Patients had a dose amplification period followed by a fixed dose period. And then a long-term open label extension study was available for patients if they had had clinical benefit or began to have clinical benefit once they were switched to open label drug. The main endpoints of the study were hemoglobin response. So patients were, it was slightly different than the phase 2 study of 1.5 gram deciliter increase or greater over 2 time points. It was the threshold for hemoglobin response and similar for the intervention arm as the placebo arm once it switched to the intervention phase. And this just shows the design of the Activate-T study, which is for the transfused patients. This was a phase 3, but now open label, no placebo arm study of mitapivat in adults patients who received 6 transfusions or more during the prior year. Again, adult patients had to have at least 1 missense PKLR mutation. And these patients too underwent a dose escalation period and then a fixed dose period, and then were eligible for this open label extension. And for this cohort, I think I put the wrong thing here. It had to be a 33% rate of reduction in transfusions over the fixed dose period as compared with the historic data. And then also the study looked at transfusion free period where patients were not transfused for a period of time. So this, and then switching back now to the Activate study, looks at the hemoglobin levels during the course of the study. So the intervention arm here is shown in blue, and 40% of patients had a hemoglobin response started on when they were started on mitapivat. You can see there was no response in the placebo arm. And then during the open label part, which is here in the dotted line, you can see the placebo arm then received drug and started to look more like the intervention arm. And then this has now been sustained over an extended period of time in terms of hemoglobin response. In addition to the hemoglobin response I'm not showing you here, there was also improvement in markers of hemolysis and markers of hematopoiesis, and improvement in disease-specific quality of life measures as well. This shows data from the Activate-T trial. So this is in transfused patients, and 33% achieved this transfusion response with a reduction in transfusions, and 22% became transfusion free, which I think is a really important number for these patients. And this shows these patients in terms of their transfusion free status over time, which has now been for more than 2 years. And then I think there's really important data that continues to come out of the extension study and is getting reported at the European Hematology meeting and the American Society of Hematology meeting in terms of other improvements that we see in patients who take mitapivat over a longer period of time. So this shows data about ineffective erythropoiesis and reduction of iron overload in patients who receive mitapivat. So you can see that there was a reduction over here, there's a reduction in erythropoietin and the erythroferrin level. We saw the reticulocytes, and then soluble transferrin receptor levels all decreased with mitapivat. And then you can see from the table that hepcidin, ferritin, and LIC measures all improved in terms of measurements of iron directly in patients who received mitapivat. And then once patients switched from placebo to mitapivat, we saw that there was improvement in that population. In addition to the improvement in ineffective erythropoiesis, we also saw that there was stability in bone health. So those bone density studies were done because there was a concern that maybe this could have a detrimental effect on bone health with aromatase inhibition. And actually what we saw over the course of the study so far and what we've seen so far is that there's a stability in bone health in these patients. And so I think there's 2 points. One is it's not making bone density worse in terms of this question about aromatase inhibition, which is very reassuring. And the second part is, is it actually helpful for bone health that has this reduction in hemolysis and improvement in ineffective erythropoiesis? And I think the answer to that is maybe, that we don't have very long-term follow. It's up to 65 months, which maybe isn't long enough to see an effect of improvement on bone health, but stability and lack of decrease is certainly reassuring. And so with this data, the FDA and EMA have approved mitapivat for adults who have pyruvate kinase deficiency, and now this is in clinical practice in these areas. And we currently now have open in the US and are working at open at many sites, Activate Kids and Activate Kids T, which are similar trials to the adult trials for looking at pyruvate kinase deficiency in the pediatric population. And so this just shows you the design of the trial that's for children who are transfused and the design for children who are not transfused. And so we're looking forward to seeing the data from these trials and being able to offer this as a potential treatment through the study for children with PK deficiency. So in the last few minutes, I'm going to talk about a few things. So one is about gene therapy, which is an exciting disease-modifying therapy that's in clinical trials. And this is based on mouse data and preclinical data looking at lentiviral transduction of hematopoietic stem cells and whether they can reverse the manifestations of pyruvate kinase deficiency. So you can see in the mouse model that in the PK deficient mouse, there's an increase in spleen size compared to the healthy mouse, and that there's an increase in reticulocytes compared to the healthy mouse, and that there's this difference in hemoglobin that you can see. And with the lentiviral vector with correcting PK deficiency, you see improvement in the hemoglobin, and you can see improvement in the reticulocyte count, and improvement in terms of the spleen size. And so it was with this preclinical data that the trial using the lentiviral vector for regularly transfused adults with PK deficiency opened in 2019 in Spain, and also a site in the US and California. And this data has been presented at meetings and not yet published and as a manuscript. The first 2 patients have been reported who received treatment, and following treatment, both patients who were transfused have had normal hemoglobin levels, improvement in their hemolytic markers, and a reported improvement in quality of life, and no transfusions with more than a year of follow-up, and favorable safety data. And so these graphs on the right show you from an individual patient, one of these 2 patients. This was the historic hemoglobin rates with also historic transfusion data. And you can see that they had the gene therapy intervention and then led to the rise in normalization. You can see up to 15 grams per deciliter of the hemoglobin, which was stable over this period of time. You can see this reduction from 50% reticulocyte count to normal that's sustained over time. And you can see this variability, of course, in the bilirubin level, but that it normalized with the intervention and sustained over time. So I think this is very promising and exciting data in a few patients. And I think we're going to continue to learn more as patients are eligible who are in the adolescent age group now for this gene therapy, and then soon after that, the pediatric age range as well. So I think we're entering into a new era for management of pyruvate kinase deficiency in terms of thinking, how do we manage these patients when we have lots of options? And of course, some are available clinically and some are only available through clinical trials, but over the next 5 to 10 years, that may continue to change. And so, trying to think about, well, who would be a patient who's a good candidate for gene therapy, knowing the risks potentially, or the unknown risks in terms of the long-term look, knowing that there's an oral therapy that is approved in some areas of the globe. And of course, knowing that our methods for stem cell transplant and conditioning continue to change over time. And so how we think about that might change too. And so this is just an algorithm that Wilma Barcelini and I put together a few years ago. This was before mitapivat was approved, for how do we think about splenectomy and transfusions and PK activators and stem cell transplant and gene therapy. And I think this is a complicated decision, and I think it depends on the patient's preferences in addition to their past history, and it requires a long conversation, I think, in terms of trying to figure out what to try first and what's the best treatment, whether it's a disease-directed treatment or a supportive treatment for a period of time. And I'm just going to end by talking about PK activators for treatment of other congenital hemolytic anemias. I know that's not the topic, but it's so interesting to think about now mitapivat and what's its role for other disorders. And of course, other more common erythrocyte disorders like sickle cell disease and thalassemia may result in a stressed state or an increased energy utilization state where the normal ATP production isn't adequate for the physiology of that disease state. And so there could be some role for PK activation, increasing red cell ATP and decreasing 2,3-DPG in order to treat these anemias as well. And this is an explanation that's been put together by some of the investigators working on PK activators in the thalassemia population, and thinking about how do PK activators work in this patient population. And the thought is that they increase ATP and in this way perhaps decrease ineffective erythropoiesis or lead to a decrease in oxidative damage, and so a decrease in hemolysis and an improvement in hemoglobin. And what's been seen in patient samples ex vivo for beta thalassemia is that PK activators are effective in terms of increasing PK activity, increasing ATP. And then in the mouse model, it was shown that PK activators do seem to decrease ineffective erythropoiesis and decrease iron overload and improve anemia. So this led to some phase 2 clinical trial for mitapivat in 20 adults who had non-transfusion dependent thalassemia with a hemoglobin less than 10. And a response was defined as a hemoglobin increase greater than 1. 80% of patients in that 20 patient group achieved that response, including all the patients with alpha thalintermedia. And there was also a sign of improvement in markers of erythropoiesis and hemolysis, so encouraging early phase 2 data. So this has led to 3 open clinical trials for patients with thalassemia. Energize is for non-transfused patients with thalassemia, Energize-T for transfused adults with thalassemia, and then Hibiscus is etavopivat, a different PK activator for patients who have both transfusion-dependent and non-transfused thalassemia. This is data from a recent Lancet publication showing that thalassemia phase 2 trial data with hemoglobin change on the y-axis over time. And you can see that rise in hemoglobin that seems to be sustained over a 6-month period of time. And then, of course, thinking about, is there any benefit of PK activators in sickle cell disease? And this is being considered for both mitapivat and etavopivat as well. And thinking that increase in red cell ATP may improve red cell energy metabolism, membranes, and integrity, and reduce hemolysis in the way that perhaps it does with PK deficiency. And maybe lowering 2,3-DPG is a reasonable idea to decrease sickling by increasing hemoglobin oxygenation. And the thought is too that perhaps this will help to improve red cell hydration through ATP-dependent mechanisms in the Gardos channel and improve red cell survival. And so there has now been 2 different studies completed for sickle cell disease, one a phase 2 single center study, just 9 adults with this improvement, though seen in anemia and hemoglobin oxygen affinity and sickling parameters. And 75% of patients had a hemoglobin increase greater than 1, although it's arguable whether this is the best outcome measure for patients with sickle cell. And then for the etavopivat trials, there was a 12-week open label study with 20 adults, and 73% had that hemoglobin increase. Again, a little question about whether that's the best endpoint in sickle cell, but there were also improvements in markers of erythropoiesis and hemolysis, and improvement in point of sickling and deformability, which is interesting. So there's now 2 trials that are open or about to be open. The Hibiscus trial, again, which is for the patients with thalassemia, but also for sickle cell, so for multiple disease groups. and then the Rise Up trial, which is a phase 2/3 trial of mitapivat for sickle cell disease. And it could be that there are other red cell disorders that might be effectively treated by mitapivat or tebapivat or other PK activators. And this is data that was shown at ASH a few years ago, looking at mitapivat and the band 4.2 mice, and showing also that this leads to an improvement in red cell parameters and this hereditary spherocytosis model. So with that, I'm going to end. I hope I've shown that natural history studies are the foundation for the clinical development pathway and clinical trials, that we need to know the disease phenotype in order to really understand what are important outcomes in these diseases and what to study in trials. Drug development perspective is really integral in the design stage of natural history studies, to make sure we capture what's needed to design those trials, to think about future trials. And collaboration is key in progress in rare diseases, as we all know that if we work together, we can learn so much more by understanding our patients as a group, and that also includes with industry. Our approach to monitoring these patients and treatment of congenital hemolytic anemia is certainly, I think, improved over the last 5 years to 10 years. And I hope there's really exciting things to come in the next 5 to 10 years. And with targeted treatment options becoming available, the accurate diagnosis for these patients has become so much more critical. And I think that's really one of the key parts of this whole talk, I think, is making sure you know which congenital hemolytic anemia your patient has, because now these patients have options, and really we understand better what needs to be monitored, but also the idea of gene therapy and targeted treatments has really transformed the way that we think about these patients. So thank you very much for your attention, and I'm happy to open it for discussion.
Thank you so much, Dr. Grace. That was so much of educational material. Your long work, you have put it up. We have learned, educated ourselves. We have a lot of our colleagues who would like to interact with you, those of you who are interested. And if you are ready to open your videos, please do so. I'm also very enthusiastic that some of our workers in this field may probably like to join hands with you and have their patients enrolled in your registry, which will be very, very important. This is a large country, so there should be a good number of patients. Probably you may not have any patients from India so far in your registry. Yeah, right. Okay, so let's have questions. Who would like to begin?
Shall I start, Dr. Arora?
Go ahead, Amita.
Thank you, Dr. Grace. It was, it was so nice to have all the data and all the work that's ongoing. For us, splenectomy still remains the one option that we can offer to patients. And in many ways, the pathophysiology seems to mimic that in NTDT or, the eventual these things. And we know from the optimal care study that the splenectomy that we were doing was perhaps not the best way forward for those patients because of the long-term complications. And many of the things that, that we see in PK deficiency are similar. So is there any work on post-splenectomized patients and, pulmonary artery hypertension, thrombosis, and all those events in them as to whether indeed, that is the optimal way, or transfusion chelation till we have mitapivat may be the optimal way?
I agree with you that splenectomy may not be the right path for patients. Yeah. Because I'm a pediatric hematologist and I see some adult patients, but I mainly see children. And of course, mitapivat, except for in the trial, which we're working on getting open here, isn't an option either. And so we're faced with that same question. Do we continue to transfuse as especially for those patients who really do need regular transfusions? Or do we consider splenectomy, knowing that for most patients it's going to decrease transfusions? And it's interesting because I think in the younger age group, when the splenectomy is effective, it seems like it's the right thing because patients have that reduction in transfusions or don't get transfused afterwards, even though they still have anemia and hemolysis. It's better than it was pre-splenectomy. But I think the registry data points to this issue. It's like a 10 to 11% rate of thrombosis, pulmonary hypertension we see in young babies, and then we see in the patients after splenectomy. And I don't know even that how carefully the registry studies are observational. It's not that, everybody gets an echo or everybody has a specific test. So, it could be that some of these complications are underdiagnosed too, because we're not necessarily monitoring for them in a systematic way. So I think we don't know the answer to that. My approach now, knowing that we have mitapivat for adults and knowing that this is going to be off, we will have the trials open here for children, is that I wouldn't do a splenectomy now, and wait to see, let's see if the drug works for you, first, because I think it could be that it's the combination of the two that will work best, but it could be that you avoid the splenectomy altogether if you really are like those patients on the right side of that hemoglobin graph who have that, 2 to 5 to 6 increase gram per deciliter in hemoglobin, then you got a much better effect from the drug than you did, potentially from the splenectomy. So I think, my advice currently is to, if you can, hold on, because things are changing. And if we just wait 2 or 3 years, maybe you'll have access to these things, and maybe we'll see what's going on with gene therapy too. It'd be nice to have that longer data, but the world of gene therapy is exploding and changing too simultaneously. So I think that it's depending on how things look in the area that you're in terms of access to these things over time, that it doesn't really make sense to rush or to say, as soon as you're 5, we're going to think about splenectomy as how we were thinking about it before in regularly transfused children who have pyruvate kinase deficiency.
Thank you. That was most useful. Yes.
Thank you, Amita, for that question. We will just alternate between the faculty and the audience. There's a question from the audience. Dr. Abhilasha wants to know, pyruvate kinase deficient patients tolerate anemia better than other hemolytic anemia, partly due to increased 2,3-DPG. Should measurement of 2,3-DPG be one of the factors in deciding about splenectomy?
I didn't really talk about this as part of the presentation, that yes, so patients who have pyruvate kinase deficiency have a change in 2,3-DPG. And so there's this thought that patients may tolerate their anemia better because of a shift in the hemoglobin oxygenation curve and a change in oxygen offloading into the tissues. And there was one study done, I think it was in the 1960s or around that time, that compared one person with hexokinase deficiency and one person with pyruvate kinase deficiency and compared their exercise tolerance. And the exercise tolerance was much better for the individual with pyruvate kinase deficiency compared to hexokinase. And one flaw of that study is it's just a comparison of 2 people, which makes it a difficult study to know what do you make of that. And what I can tell you from my understanding of these larger groups of people who have pyruvate kinase deficiency is that there's a wide variation in terms of the symptoms that patients have. So some people who have a hemoglobin of 6.5 or 7 feel very well. They go, able to go to work. They're able to exercise. They feel well, and maybe they do feel better than a patient with another type of anemia with a similarly low hemoglobin level. But there are other people with pyruvate kinase deficiency with a hemoglobin of 9 who feel very unwell. And so, I think, measuring 2,3-DPG isn't a clinical test that we can regularly do to know, well, why is there such variation from person to person with pyruvate kinase deficiency? And so I don't think we have an understanding of why there's so much variability, but for sure that factors into any intervention. So if you have a patient who feels well and is doing everything that they want to do, they may not need anything done, even if they're eligible for a splenectomy, eligible for mitapivat. I think, where we have opportunity is looking at that long-term data of mitapivat and seeing, well, what does it do for ineffective erythropoiesis and bone health and iron overload? And maybe those will be things to think about in the asymptomatic patient from their hemoglobin who may have risk of long-term complications. But I talked a lot about interventions, but they're not necessary for everybody who has this diagnosis. It really depends on what the patient's telling you about how they feel. That so much of this is based on the quality of life and impact of the disease on the patient, which can be quite variable.
Thank you. That was a beautiful reply. Dr. Deepak Bansal, your question.
Hello, Dr. Grace. I think you've given us overwhelming information on a disorder which is not so common. And on an individual case-by-case basis, we do struggle on deciding the management. So asking the same what Dr. Amita Mahajan had asked, let's say we have a 2-year-old child with PK deficiency in the clinic, and we do struggle to decide how best to manage. I mean, should we continue transfusions and then consider splenectomy at 5 years of age? Or should we consider partial splenectomy at 2, so that in an attempt to reduce the number of transfusions, because when we transfuse, then one has to start iron chelation. So it's a struggle, and you've spoken so much about mitapivat. Can you tell us when it's possible that it would be available in the rest of the world, and how would it be priced? Is that something possible for you to communicate to us, that how expensive would it be, and would it be possible in the rest of the world that it may be used? Although I do understand that in children, it's still not licensed. So, and I'm just curious to know your experience with partial splenectomy in other disorders like hereditary spherocytosis, etc. And do you see long-term complications with splenectomy in adults with hereditary spherocytosis? I mean, we keep on really worrying about splenectomy, but do we see bad complications with splenectomy in older individuals with, let's say, hereditary spherocytosis? Thank you.
Well, those were a lot of great questions. Let me see if I can try to take them one at a time. So one is about partial splenectomy for pyruvate kinase deficiency. From what I know about patients who've had partial splenectomies, which is a very small number, it's not effective for pyruvate kinase deficiency. So I would only think about partial splenectomy and hereditary spherocytosis, which we consider that quite a bit. And depending on the patient's clinical course and decision-making with the family about full versus partial splenectomy. So that's the population where I think about partial splenectomy, but I don't think of it as a temporizing measure in pyruvate kinase deficiency. So I would be thinking full splenectomy or no splenectomy. The timing of that is really in consideration of infection, even with vaccine optimization and prophylactic antibiotics, it is probably better to wait until a child is 5 versus 2, but you're up against, as you said, transfusions and chelation therapy and the risks and downsides associated with both of those. In that Amish population that I mentioned when I was talking about splenectomy, that population in the United States doesn't have insurance, and so there are financial reasons for the patients to undergo splenectomy at a younger age. And that patient population, interestingly, didn't have a difference in infection or sepsis after splenectomy. But it's still a small number of patients, so hard to draw on that. The age difference of 2 versus 5. I think the other questions about, or the question about should you have a splenectomy, should you continue to transfuse, I think goes back to what I was saying earlier, that especially for a patient who has a missense mutation, if their genetics, then I think consideration of waiting to, if you think that mitapivat may be coming, waiting to do the splenectomy and trialing that before undergoing that surgical procedure to see if there can be benefit within oral medicine. But I think it's definitely a challenging decision right now. And this disease is different than hereditary spherocytosis. There's ineffective erythropoiesis that we really don't see as much with hereditary spherocytosis. And although patients with spherocytosis can develop iron overload, we see it at a much greater rate in PK deficiency, more like xerocytosis than spherocytosis. So I think, they're not really comparable. For splenectomy after spherocytosis, people have tried to study that the question about thrombotic risk, it's probably similar to the healthy population, because it seems like it's difficult to study where there's an increase in thrombotic risk in healthy individuals too. And it may not be that increased after splenectomy and hereditary spherocytosis compared to like trauma-associated splenectomy in the healthy population. But I think we don't see as much that rate of thrombosis, pulmonary hypertension, other complications we see in some other red cell disorders like pyruvate kinase deficiency. So even though it's more common, I feel like we can't compare them because they're not the same, even though they're both congenital hemolytic anemias. The pathophysiology is different, and the rates of other complications. are different too. And you ask a very good question about mitapivat. You know, I'm an academic clinician, a researcher. I don't have any, gain from mitapivat in any way, from an economic perspective. And I always worry myself too, if you have a rare disease and there's a company that's developed a drug in that rare disease, how much that's going to cost. And it's always worrisome. And we as people in hospitals have no control over that part of things. And so I do think the drug in the US is quite expensive. There's efforts from the company to make it available, for people and to figure out ways to make sure that the drug gets covered so that people who have this rare diagnosis have access to it. So it depends on kind of whether that support is there across the globe as it becomes more available elsewhere. The trials in children are happening now. The first patient's been enrolled in that trial, I think in July. Those trials. So that it really is getting started in terms of the pediatric trials, and they are open a little bit across the globe, I would say, and Europe and beyond and North America, but they're certainly not open everywhere. And I've heard from families where they don't have access to the trial and trying to figure out how to participate. And it's disappointing not to be able to get access when other children can. And so I hope it will come to your area soon, certainly for adults. And though I don't know what it will be like, though, in terms of expense and the ability of people to really access it where you're practicing.
Right. Thank you so much.
Thank you. We'll take one question from the audience. Dr. Arihant Jain wants to know, what is the median lifespan? What are the causes of mortality? And are these different in those who are transfusion dependent and who are transfusion independent?
I don't think we know the answer to all those questions. I mean, that's why we need these registry studies. So I didn't mention, the pyruvate kinase deficiency natural history study had that 2-year follow-up. But actually now what's happening is there's another registry that's building upon this natural history study called the PEAK registry, where patients are being followed for up to 10 years. So trying to get an even longer look at what happens over time prospectively. We know the oldest person in our registry was 70 when they enrolled, but I don't think it's because something happens when you turn 71 or 2 or 80. I think the diagnosis has been made more easily over time. It still is challenging to make a diagnosis. So I think people who are older have the same issue, but may not have been diagnosed because or have the wrong diagnosis because the enzyme testing and genetic testing wasn't made available, in their early lifetimes. And from what we know, there are patients who die of complications of this disease related to iron overload, in particular, like cardiac iron overload, which is less common than liver iron overload, but happens in this patient population, or of course, sepsis related to splenectomy. But patients, I think, mainly die of other complications that are unrelated or seemingly unrelated to pyruvate kinase deficiency, but we don't really know. I mean, we really need registry studies, and the disease is rare. It's very hard to look at this, but this is why I would encourage everybody, to think about this PEAK registry, or think about a separate registry to really have a better description of what happens to people who have this over time. And that helps in making decisions about treatment too, to know, well, if die of iron overload, should we pay attention to that or not? Of course, I think the answer is yes, we should. But for some of these issues related to splenectomy and transfusions and decision-making may be easier to make in the setting of knowing long-term outcomes.
Thank you. Dr. Jagdish Chandra.
Dr. Grace, that was really very nice talk. My question is regarding use of the drugs which are used for ineffective erythropoiesis, the targeting ineffective erythropoiesis like luspatercept. Are such compounds also tried in PK deficiency? Because as you said towards the last few slides of your presentation, the mitapivat has been used in conditions like thalassemia and sickle cell disease, where there is no PK deficiency, right? So is it the other way around? Though there is some data on with conflicting results that PK deficiency is also associated with some ineffective erythropoiesis. So is there any work on luspatercept type drugs being used for PK deficiency?
That's a really interesting idea. As far as I know, nobody's tried that or has looked at it, but I think that would be interesting to look at.
Thank you.
Thank you, Dr. Jagdish. We'll take one more question from the audience. Are there clear-cut indications when you will advise stem cell transplant to these patients?
I missed the beginning of that question. Are
there clear-cut guidelines when you will advise stem cell transplant to these patients?
No. So one thing that is happening now is there is a group that's working together to look at, and I tried to show you the evidence that's available. You saw too that there's, 16 patients that were reported. That study was a few years ago, so maybe there would be a few more patients now. But the data about outcomes and people with pyruvate kinase deficiency who've had a transplant is just so minimal that it makes it hard to make a decision, makes it hard to have an informed discussion with a patient or their family. There's a group now that's getting together to look at the evidence that's available and try to make recommendations for management in terms of monitoring, but also in terms of supportive treatment and new targeted treatment or sort of old transformative treatment like stem cell transplant. And so it may be that having a separate kind of more critical look at the data and I guess in a more rigorous way will help us to make recommendations about those things. But I think it's a challenging discussion with a patient and a family about, where do these things fit together? Splenectomy and continued transfusions, stem cell transplant, gene therapy. It's hard in clinical practice to have this complex conversation about all these things and even make a recommendation. But I generally don't recommend stem cell transplant to young patients. That supportive treatment, at least from my perspective, seems more known in terms of outcomes. And especially if patients can be properly chelated, effectively chelated, it seems like a safer approach, especially as these new targeted treatments are coming along and the options may change over the next 5 years. That conversation is easier in a 2-year-old, because then you looked at the outcomes and you have time before they turn 10, where the outcomes seem to be different for stem cell transplant. I think it's harder if you see somebody who's closer to that age group and you're trying to make the safest recommendation.
Thank you. Dr. Abhilasha?
My question is regarding another enzyme deficiency. I have a huge cohort of GPI deficiency. So my question is mitapivat likely to work in GPI deficiency as it is a proximal enzyme?
I don't know. You should create a registry if you have a big population of patients with that diagnosis. Because I think, in our practice, we have maybe 2 patients. So I think, and that's another, all these rare enzymopathies, need their own study, because I don't think they're all the same. We know they're not all the same. And even, non-hematologic complications occur in many of the enzymopathies. And so they each deserve their own study from my perspective. But I do think there's, it may be that mitapivat is beneficial across different red cell disorders. And I wonder too, if after it's studied in children and perhaps if it's, if it's safe and effective and it could get approved in children and adults, if people will be able to use it, off label a little bit more for some of these even more rare disorders where it will be hard to do a study, in an enzyme disorder that's even more rare than pyruvate kinase deficiency. But I have the same question as you, which red cell disorders is this going to work in? And in pyruvate kinase deficiency, we tend to see whether it's effective in just a few months. So it's not like it would need a long trial to see if it's going to be effective. So I think, it will be, it's going to be hard for a company to be interested in studying the drugs in these small hematology populations. And so it will take, clinicians like ourselves, I think, for trying to figure that out when the drug is more accessible to all of us.
Thank you. I have another question. What I have observed in a couple of patients that hemoglobin response was robust after splenectomy. But after a couple of years, there was no response. Like they were back to transfusion. So what could be the possible reason for this?
I've had that experience myself too. And, I always look to see, is there an accessory spleen or something like that that might explain why all of a sudden the hemolysis picked back up again. So, looking carefully for something like that is always worthwhile. Making sure that there is not another process that's not necessarily related to pyruvate kinase deficiency that's evolved is important, like a vitamin deficiency, thyroid disease, other things that could affect red cell production, really thinking outside of the pyruvate kinase deficiency, red hemolysis differential diagnosis or poor production erythropoiesis. But I don't think it's always clear. And as a pediatrician, I wonder too if something changes in adolescence for some patients. But I couldn't tell you what it is either. But I've done that same thorough look for the accessory spleen and vitamin deficiencies and other non-pyruvate kinase deficiency factors, and haven't found a clear answer in patients where I've seen that too. I think too, the other thing that sometimes happens is it seems beneficial, but then actually as a patient gets, into an adult age or gets a little bit older and they need to do more things every day, that anemia, the improvement in the hemoglobin doesn't feel as beneficial as it once was. So that even if the hemoglobin's been 8.5 after splenectomy, and that's what it is in somebody's 30s or 40s too, when they get to that age, now they are having trouble getting through the whole workday or, getting through with their family on the weekends and all the things that need to get done. So I think, what is manageable at a certain hemoglobin as a young person becomes sometimes less manageable as an adult, even if the hemoglobin's the same.
Thank you.
Thank you. One more question from the audience is related to, do you have patients who have pyruvate kinase deficiency and sickle cell trait or thalassemia trait? And what is the effect?
I don't have patients like that, but I do think there have been patients described like that. And there has been this question. I mean, that sort of was before there were studies in patients with sickle cell. There was this question, that could it be beneficial in other red cell disorders, in particular sickle cell? And I'm interested to see the data on this too, about thalassemia and sickle cell. And I don't know what it's going to show either. In particular in sickle cell, the goal isn't to raise the hemoglobin. The goal is to transform the patient's phenotype, in terms of pain and other complications. So I think we need to see what happens with that. And those early studies really looked at hemoglobin as the measurement, which isn't the most important outcome in sickle cell disease.
Thank you. Dr. Siddharth.
Dr. Grace, thank you for that wonderful talk. So I'm going to ask you a very basic question. When we see a child with clinically suspected hemolytic anemia, we usually use a three-tiered approach to establish the diagnosis. The first tier is a complete blood count with the reticulocyte count and a peripheral smear. The second tier is when you do osmotic fragility or a hemoglobin variant analysis or an enzyme levels. And then the genetic diagnosis is at the third level. Now that in India, we do have reasonable access to getting a genetic diagnosis with NGS, can we jump from the first tier that we know this child has hemolytic anemia and directly do the NGS without doing all these NGS and osmotic fragility? Would there be any pitfalls in doing so? That's
an interesting question. We we have the same kind of approach too here in terms of that tiering. And it's interesting too, because I think sometimes also, well, if a patient has hereditary spherocytosis, if we're thinking about doing a splenectomy and there's not a family history, then I still kind of go back to the question about genetic testing. Should we make sure we know exactly what this diagnosis is before we do a surgical procedure? And should we base that on a genetic test, since we have that available to patients now? So I think, the evolving role of genetic testing is really interesting in terms of, thinking about where does it fit in best. And I do think there's something to be said for the partnership of functional testing and genetic testing and making a diagnosis for a patient. And of course, we tend to think of patients as being straightforward, right? That they have hereditary spherocytosis, and we know it's because of this gene, for example. But what we sometimes see if we do a congenital hemolytic anemia gene panel is that a patient has, for example, autosomal recessive hereditary spherocytosis. Oh, and they have a piezo1 variant, and maybe they have a component of xerocytosis too. And so this has added a whole new thing to think about in terms of, well, then what's the risk of splenectomy in that patient? And is the variant in the piezo1 and question about xerocytosis, is that a pathogenic variant? Is it a variant of uncertain significance? And we need to figure it out further with parent testing. So the pitfall of genetic testing, I guess, to some degree, is you uncover things that make it even harder to figure out what to do with your patient, but certainly make it a more thoughtful decision in terms of what to do with your patient. So I guess I didn't really answer your question about whether you could jump from the initial testing to the genetic testing. But I guess it's just to say that I think there's a role for functional testing too, especially since the genetic testing isn't always totally clear. And sometimes we get the genetic testing back, for example, this patient with recessive HS and then has piezo mutation, then maybe they need ectocytometry. We're kind of back to the functional test in terms of figuring out what's going on with that patient. So I think there's a role oftentimes for both if you can do both types of testing.
Thank you.
Thank you, Dr. Siddharth. We have two questions from the faculty, Dr. Shruti and then Dr. Amita. Dr. Shruti, go ahead.
Hello, ma'am, and extremely grateful to you for that talk. I just wanted to know that, we talked of bone mineral density defects in patients with pyruvate kinase deficiency. So are these seen only in patients who are non-transfused, or even with patients who are, maintaining appropriate hemoglobin? And what would be the appropriate hemoglobin? What level would you like us to maintain in a young child, like 2.5, 3-year-old with pyruvate kinase deficiency?
I think those are great questions. In terms of the bone density question, I don't know that we know the answer to that, except to say that it's patients who were on both of the phase 3 trials, so those who were not regularly transfused and those who were regularly transfused had DEXA scans coming into the trial. So those were the data that I showed are representative of the whole population, and there was that very high rate of bone density issues. So even in patients who are regularly transfused, we don't really suppress the erythropoiesis that well, I think, in pyruvate kinase deficiency. And so I think the answer is that all patients are at risk for bone health issues, and that transfusions, it may be that they're helpful in terms of bone health, but I'm suspicious that they may not be transformative in terms of avoiding bone issues. So I would have I would screen all patients regardless of how they're being managed. And those trials enrolled individuals who are 18 and older. And so we don't really know when does this start, to know, well, when do we need to start paying attention? And I think that needs further study. And maybe we'll learn that from the pediatric trials too, where patients have bone health being looked at as part of that trial too. But maybe it starts in kind of the teenage years, which is why I was making the suggestion that perhaps we should be looking in adolescents at least once at bone health. And then in terms of the transfusion threshold, I think that gets back to that earlier question, for patients who maybe feel well, despite their low hemoglobin level, how should we manage those patients? And do they even need anything done, or should we just observe them? And I think this is where there's some level of unknown about pyruvate kinase deficiency, but I don't think we can always draw on other congenital anemias to say this is how we should practice in this disease too. So we can't take our information we know about thalassemia and say this is how we should manage patients with pyruvate kinase deficiency, at least based on what we know right now. So I wouldn't pick an automatic hemoglobin threshold and say, well, for this child, if your hemoglobin gets less than X, we're going to transfuse you, unless at that hemoglobin threshold, the family notices the child's totally different. Once their hemoglobin's less than this, they don't want to get out of bed, they don't want to go to school, they can't focus at school, the teachers notice they're not, doing what they need to do. Then you kind of see the hemoglobin threshold, but some children won't ever have that. And other ones, will, and it will be different from child to child. So I think, it's unsatisfying to not say, well, it's for this hemoglobin, we're going to manage everyone the same. But it seems like, until we know something that tells us, well, that's the right thing to do in terms of all these complications and other issues, we really should be going based on patients' symptoms for the most part. And so I think I would evaluate how the child feels and what everybody in their community notices about them to make a decision about how high the hemoglobin needs to be. There is a threshold where you wouldn't want someone to be lower, that if it's very low, they get a virus, they hemolyze, their hemoglobin's 2.5, you don't want the child to be in that situation. So I think it's not that there's never a hemoglobin that you would say, we don't want it to be less than 5. I think there's a threshold where you would have a cutoff. But I think in general, in thinking about patients, I would use their symptoms as a guide for what hemoglobin threshold keeps them feeling well and for young children growing well.
Thank you for that answer.
So Dr. Agarwal, I think you are muted. We're unable to, yeah.
Yes, Amita, your question. Yeah.
I just have a very practical question. If cost and access were not, real issues, and we were to give Mitapivat to a patient, the response rate from the study seems to be about 40 to 50%, and it seems to plateau after 8 to 10 weeks of, starting the drug. So what would be an adequate therapeutic trial of this drug? And do you withhold transfusions if the patient was transfusion dependent to be able to actually, assess the response or, or maybe have a little more permissive anemia to give it time to show response? Just pragmatic issues, really.
I think the drug tends to be pretty rapid in terms of onset in most patients. For sure, by 4 to 6 months, you would know if there was going to be a hemoglobin effect. The majority, it was much sooner than that, but there were some patients that had a late effect. And so, kind of allowing for that potentially longer time of wanting to see if there's an effect, you could say that is 4 to 6 months as a trial. For the transfused adults in the trial, patients were seen at regular intervals. And the idea was to kind of reassess the need for transfusions at the same frequency that they had been assessed previously. And if you saw that the hemoglobin was not meeting that same kind of threshold where you were on the schedule before, then you would push off the transfusion. And in that way, that's how they saw who needed fewer transfusions and who really didn't actually need a transfusion. So I think that as we've been talking about, the decisions about transfusions are in many ways subjective to some degree, which is why I think we see the same response rate in patients who are transfused versus not transfused, that it has a lot to do with how much PK protein is there. And so I think in terms of a trial, it would be relatively straightforward to do in clinical practice. And I wish accessibility and cost weren't a factor, so that way it could just be trialed in our patients.
Thank you. Just some short questions from the audience. Is there any experience about pregnancy in these patients?
That's an important question. And there are papers describing pregnancy in people with pyruvate kinase deficiency. And we have some of that data in our registry as well. It definitely, so first is to say that people with pyruvate kinase deficiency can have healthy children and can have successful pregnancies. That's clear based on what we know from the publications previously in the registry. We do know too that pregnancy does increase hemolysis in individuals, and so there often can be a need for transfusions during pregnancy, even in people who didn't get transfused before. And then in thinking about other things related to pregnancy, what's the role of an echocardiogram before pregnancy or early in pregnancy? Supporting with folic acid, making sure that individuals don't receive iron, prenatal vitamin with iron, that since iron is such an issue that, wouldn't want someone to take more iron while they were pregnant. And then close monitoring of the fetus and the fetal development during the pregnancy. Since it's autosomal recessive, most individuals with pyruvate kinase deficiencies, children, won't have pyruvate kinase deficiency. And so management, there's, the management of the healthy carrier who has a baby that they're pregnant with who has pyruvate kinase deficiency in terms of thinking about pregnancy. And then there's management of the pregnant person who has pyruvate kinase deficiency with likely a healthy newborn. But it's important for people during their pregnancy to have close communication between their obstetrician and the hematologist in terms of monitoring and thinking about transfusion support.
Thank you. Two small questions. One is about, is there an effect on RBC indices?
I missed what you said, I'm sorry.
Pyruvate kinase deficiency, are the RBC indices altered? The MCV, MCH, MCHC, are they altered? Indices.
Are they altered? Yeah. So the MCV depends on, patients with pyruvate kinase deficiency, depending on whether they've had a splenectomy or not, have variability in their reticulocyte count. So the reticulocyte count, especially after splenectomy, can be on the order of 40 to 50%, in which case the MCV can be elevated with a wide red cell distribution because of the presence of such young red blood cells. And so it can be altered in that way. Unlike spherocytosis, xerocytosis, the MCH and MCHC are not as helpful in enzymopathies or in these conditions, in pyruvate kinase deficiency. In the morphology, as I mentioned too, especially before splenectomy, there's polychromasia, but there's not a clear red cell morphology that tells you that this is what's going on with the patient. And in fact, that hemolysis, congenital hemolysis with a bland morphology should make you suspicious that there's an enzymopathy. Because of the absence of specific red cell forms.
The last question is, spiculated spherocytes, do they suggest pyruvate kinase deficiency?
After splenectomy, you tend to see those. Before splenectomy, there can be some, but it's not typically as obvious. After splenectomy, there can be many spiculated red cells, and that's where the morphology is consistent more with pyruvate kinase deficiency, but you should know that that's what it is before the splenectomy. But there is definitely speculation of the red cells that you see after splenectomy.
Is it specific or it's non-specific?
I would say it's not specific. Yeah, I mean, I think, if a patient is diagnosed with hereditary spherocytosis, undergoes a full splenectomy and has this increase in reticulocyte count, that, of course, is not consistent with spherocytosis, and then should make you think about rare enzymopathies, including pyruvate kinase deficiency. But pyruvate kinase deficiency isn't the only enzymopathy where you have a rise in reticulocyte count after splenectomy.
Thank you. Those were the last questions. So we come to an end of this wonderful webinar. Great lecture, a very long, very, very educative question and answer session. We are extremely thankful to you for sparing your time, and a lot of people have benefited, and in turn, I think the patients will benefit. There is one little question left. How can Indians enroll their patients into this registry?
So I think I'm happy to work with you I agree with you that there should be a site that's open in India to enroll patients into the PEAK registry, that is something that's missing right now from that registry and would be such an important contribution. So I think it would take talking with the leaders of the PEAK registry, which is through Agios, the company that runs the registry now. So the prior one I ran, but now the company runs the registry. But trying to have them open the registry in India would be important, perhaps co-located with your red cell expert lab that does the genetic testing to help identify the patients who are affected.
Thank you. Thank you, Dr. Grace. That's all. And
thank you so much for having me.
Bye-bye, and thank you.
Bye-bye. Thank you.